A collection agency called Sarah in Ohio at 8:47 in the morning on a Tuesday. She had health insurance through her employer. She had seen an in-network doctor. She had paid her copay. She had done everything the system told her to do. The collection was for $3,200. It had already been on her credit report for 61 days. This was the first she'd heard about it. The hospital had submitted the claim with the wrong billing code. The insurer denied it. The hospital never fixed the code. They sold the debt instead. Sarah didn't know any of that yet. All she knew is that her credit score had dropped 94 points. There is $220 billion in outstanding medical debt in this country. Not from people who skipped their bills. Not from people who gambled on being uninsured. From people who had coverage, saw their doctors, paid their copays, and got handed a collection notice for someone else's paperwork mistake. That is what this video is about. And when you understand exactly how it works, you will never look at a medical bill the same way again. According to the Kaiser Family Foundation, 41% of American adults have medical or dental debt. That number includes people with employer-sponsored insurance, people with Medicare, people with Medicaid. Coverage is not the same as protection. And the reason for that gap is a billing system so deliberately opaque, so structurally chaotic, that mistakes don't just happen. They are expected, absorbed, and routed directly to the people least equipped to fight them. The median amount per person sitting in medical debt collections, $2,400. That's not a catastrophic surgery. That's not a cancer diagnosis. That's a routine procedure, a lab test, an ER visit. That's an amount that will never feel worth hiring a lawyer over. An amount just small enough that most people eventually pay it to make it stop. That math is not a coincidence. Here's something the hospital industry does not advertise. A 2022 study published by the Journal of the American Medical Association found that roughly 80% of medical bills contain at least one error. Not edge cases. Not unusual circumstances. 8 in 10 bills. If you've received more than one medical bill in your life, the odds are not in your favor. Here's the thing. The hospital billing system in the United States is not broken. It works exactly as designed. The question is, designed to do what and for whom? To understand that, we need to go inside the machine. Most people assume hospital billing is simple. You get care, the hospital sends a claim to your insurer, the insurer pays their share, you pay your copay. That's the contract. That's what the card in your wallet promises. But that description skips over a multi-step back-office process that involves specific procedure codes, diagnosis codes, modifier codes, coordination of benefits rules, timely filing windows, and network verification steps, any one of which, if missed, can cause an insurer to reject an entire claim. And here's the part that should make you stop and reread that sentence. The hospital created the error. The hospital missed the window. And the hospital's solution, in a documented, systemic, financially incentivized pattern, is to bill you. And here is what the hospital does with a rejected claim. It doesn't always call you. It doesn't always resubmit to your insurer. In many cases, it quietly reroutes the bill. It bills you directly, the patient shititan, sometimes without any prior notice that the claim was denied. Sometimes the bill goes to an old address. Sometimes it goes to the right address and looks like an EOB, an explanation of benefits, not a bill. Sometimes it gets sent once and the hospital marks it as received because the postal service delivered something to your zip code, and that's close enough. And then the timely payment window closes. And here's where it gets interesting, because this is where a third party enters. Major health systems across the country do not manage their own collections. They outsource the billing function entirely to revenue cycle management companies. Two of the largest are Ensemble Health Partners and R1RCM. These are not small operations. R1RCM reported over $2.2 billion in revenue in 2023. Ensemble Health Partners manages billing for hundreds of hospitals across dozens of states. Their entire business model is built around one thing: extracting maximum reimbursement from every encounter. That means insurance, yes. But when insurance doesn't pay, for any reason, including reasons the hospital created, it also means you. These companies do not profit from resolving disputes. They profit from resolution, meaning payment. The difference matters. Ask yourself this: when was the last time you read the financial responsibility form you signed before receiving care? That single document, handed to you in a clipboard stack while you were anxious about your health, is the legal instrument that allows the hospital to bill you directly if insurance doesn't pay, for any reason, including their own error. You signed it. Almost everyone does. When a claim gets denied for a procedural reason, let's say the hospital submitted with an incorrect billing code or submitted one day outside the insurer's timely filing window, which is typically 90 to 365 days depending on the plan, the revenue cycle company has a choice. It can appeal the denial, correct the code, and resubmit. That takes time and labor. Or it can rebill the patient, send a notice to an address it may not have verified, and after 60 to 120 days pass without payment, assign the account to a third-party debt collector. Third-party debt collectors purchase medical debt, sometimes for as little as 3 to 5 cents on the dollar. They then attempt to collect the full balance. Every dollar they collect above their purchase price is profit. So a $3,200 bill they bought for $160 is worth $3,040 in margin. That is a powerful financial incentive to collect aggressively, to work quickly, and to never look too closely at whether the bill was accurate in the first place. Does the collector know the claim was denied due to a hospital coding error? Sometimes. Do they have access to the original claim, the denial notice, the insurer's explanation? Not always. Are they legally required to investigate the accuracy of the underlying debt before reporting it to a credit bureau? Under the Fair Debt Collection Practices Act, not proactively, no, they report. You find out when your credit score drops. The CFPB documented something that sounds almost too cynical to be true. Medical debt is routinely reported to credit bureaus before the patient has received any formal notice that the debt exists, not before they've disputed it, not before they've had a chance to pay it. Before they know it exists. If that sounds backwards, it is. It is legal, and it happens constantly. A 2023 CFPB report found that medical billing errors, including duplicate charges, incorrect codes, and insurance coordination failures, are among the most common sources of disputed debt in the United States. The Bureau also found that medical debt frequently appears on credit reports before the consumer has any knowledge that the debt exists. Let's talk about what incorrect billing code actually means in practice, because this is not a minor clerical issue. Hospital billing uses a system of codes, ICD-10 codes for diagnoses, CPT codes for procedures, that numbers in the tens of thousands. A single procedure can be billed under multiple codes depending on how it was performed, what equipment was used, how long it took, whether there were complications. The code selection determines whether your insurer covers the service, at what rate, and whether it falls under your deductible or copay structure. Coders make mistakes. Systems auto-populate the wrong code. A procedure billed under one CPT code is covered. The same procedure billed under an adjacent code is denied. The denial comes back from the insurer. And here is the exact moment that determines whether you ever find out, or whether you find out 90 days later when a stranger calls to tell you your credit score is gone. If the billing department catches the error and resubmits before the insurer's timely filing window closes, you never know any of this happened. Your coverage works exactly as advertised. But here's what most people don't realize. That window is often 90 days. The revenue cycle software flags it. A human being, or more accurately an automated triage system, looks at that flag and makes a priority decision. High-dollar denied claims get worked. Low-dollar denied claims, the $800 lab panel, the $1,200 anesthesia charge, sit in the queue. The queue grows. The window moves. And one morning, the system marks it. Timely filing expired. The claim is now legally uncollectible from insurance, not because of anything you did, because the queue was long and your bill was small. At that moment, you become the most efficient available collection target. Not because you're responsible, because you're reachable. Here's what most people don't realize. There is no federal law requiring hospitals to notify patients before sending a medical account to collections. Some states have passed notification requirements, but those laws vary. They have enforcement gaps, and the debt collection industry has successfully lobbied against uniform federal standards for decades. The CFPB attempted to implement a rule in 2022 that would have removed medical debt from credit reports entirely and changed how collectors handle medical accounts. That rule faced sustained legal and legislative resistance, and as of early 2025, its implementation remained contested. In the absence of a uniform standard, each hospital system sets its own notification policy, and revenue cycle management companies operate across multiple states under multiple contracts with varying protocols. So let's do the math. The median medical debt in collections is $2,400. That's the number for the average person. But that's a median, which means half of cases are higher, and the cases that drive this system are not the $200 ones. Let me show you how a single billing failure scales. A routine outpatient surgery. Let's call it a laparoscopic procedure, something common, covered under your plan as a participating provider service. Your out-of-pocket maximum, $4,000. Your copay for the procedure, $250 paid at check-in. The hospital submits the claim. The primary procedure code is correct. But the anesthesia billing is submitted separately by a different billing entity. Anesthesiology groups often contract independently from the hospital, and it comes in 47 days after the insurer's 45-day secondary provider window. One claim, 2 days late, Denied. The anesthesia biller sends one statement to your home address. You think it's an EOB, they look almost identical, and you set it aside. After 60 days, the account is sold. The collector reports it. You just accumulated $1,800 in collections debt from a procedure your insurance would have covered if the bill had arrived 2 days earlier. Your credit score drops between 60 and 100 points. That credit score drop increases your interest rate on the next car loan you apply for. At current average auto loan rates, a 70-point drop on a $25,000 and 60-month loan costs you roughly $2,100 in additional interest over the life of the loan. So the $1,800 billing error cost you $3,900 in total, and you paid your copay. Now hold that number, $3,900 total cost from a $1,800 billing error. And consider this, the debt collector who purchased that account paid approximately $54 for it. They collected $1,800. Their profit on your billing error, $1,746. No one in this transaction lost money except you. Every other party was made whole or turned a profit on an error they did not make and had no legal obligation to correct. Multiply this across the 41% of American adults with medical debt, 100 million people according to KFF data, and you have a system generating $220 billion in outstanding claims, a meaningful portion of which traces back not to unaffordable care, but to back-office failures that were never corrected and never needed to be, because the cost was transferred to patients before anyone ran the audit. That is not a bug. That is a revenue pathway. Look, there is a case to be made that revenue cycle management exists because hospital billing is genuinely complex, and that insurers bear significant responsibility for creating the coding labyrinth in the first place. That case is correct. The labyrinth is real, the complexity is real, and insurers built substantial parts of it. But here's why that argument doesn't fully land. The revenue cycle management companies are not neutral administrators trying to navigate a confusing system. They are incentivized to extract revenue. Their contracts with hospitals are often structured around collection rates and recovery percentages. The more they collect, from insurance or from patients, the better they perform. That incentive structure creates a specific kind of pressure. Move accounts out of disputed and into resolved. And the fastest way to do that is to resolve against the patient. R1RCM's investor materials describe a technology-driven approach to revenue cycle management that reduces revenue leakage. That phrase, revenue leakage, is how the industry describes money that insurers don't pay, that patients dispute, that gets written off. In the revenue cycle framework, a billing error that patients successfully dispute is leakage. An uncontested collection is a recovery. You can draw the line between those two outcomes yourself. Ensemble Health Partners manages over $40 billion in net patient revenue annually across more than 900 hospital facilities. At that scale, a 1% increase in patient-side collection rates on ton, meaning collections from patients rather than insurers, is $400 million. The incentive to pursue patient collections aggressively and to route denials toward patients rather than rework is not incidental. It is arithmetically enormous. And here's what makes this system particularly resilient to accountability. The billing failure and the collection happen through separate entities. The hospital blames the revenue cycle company. The revenue cycle company says it followed the hospital's protocol. The debt collector says it received a valid debt assignment. At every step, responsibility diffuses. No single actor owns the whole chain. No single actor made the wrong decision that you can clearly name and challenge. This is by design. Here's a detail that tends to land differently the second time you hear it. R1RCM is publicly traded. Its stock is analyzed by Wall Street. Its quarterly earnings calls discuss patient yield optimization. That phrase, patient yield, is a financial term. You are the yield. The optimization is directed at you. Now consider what it takes to fight back. You find out through a credit monitoring notification. Your score dropped 83 points. You log in. You see a collection, a company name you don't recognize, an amount you don't remember owing. This is day one of what the industry is counting on taking you at least 90 days to resolve, if you resolve it at all. Day 1 through 30, you track down who actually owns your account. The collector may be a third party that purchased it from a second party that purchased it from the original billing company. Each transfer is legally documented, but not publicly searchable. You send a written debt validation letter. The collector has 30 days to respond. Day 1 through 30, simultaneously. You call the hospital's billing department and request an itemized statement. You are legally entitled to this. The hospital has up to 30 days to provide it. The format will likely require medical billing knowledge to interpret. You will receive a document that lists CPT codes next to dollar amounts with no plain language explanation. day 1 through 30, also simultaneously. You contact your insurer and request the full claim history for the date of service. You are trying to find out whether a claim was submitted, whether it was denied, and why. This call takes between 45 minutes and 2 hours. You will be transferred at least once. Somewhere in week 3, if you have been thorough and lucky, you discover that the original claim was denied for timely filing. You now need to determine whether the denial was the hospital's error or the insurer's. This requires a 3-way conversation between you, the billing department, and the insurer, none of whom are obligated to speak to each other on your behalf. If you can prove the error originated with the hospital or its revenue cycle company, you can demand they recall the debt from collections. Some will. Many will not, because recalling the debt means acknowledging a mistake, which creates liability. Meanwhile, the collection is still on your credit report. You now file disputes in writing with Equifax, Experian, and TransUnion separately. Each has its own process, its own timeline, its own evidence requirements. Removing the item from one bureau does not remove it from the others. Each dispute takes 30 to 45 days. You are now in month 2. You have spent, by a conservative estimate, 12 to 18 hours on this. You have not recovered a single dollar. The collection may still be on your report. And here is the thing the system is counting on. You have a job, you have a family, you have other things happening. The complexity is not accidental. Attrition is the strategy. Most people at some point in this timeline calculate that it is easier to pay the $2,400 than to spend another month fighting it. That calculation is exactly what this system was built to produce. Here's why this works on people. Not just that it does, but why. The first thing is what behavioral economists call ambiguity aversion, the tendency to freeze when you don't fully understand a situation. Medical billing is deliberately ambiguous. The codes are opaque. The denial language is technical. The collection notice uses legal formatting designed for intimidation, not comprehension. When people encounter a bill they don't understand, the instinct is to wait, to gather more information before acting. And every day they wait, the dispute window narrows and the credit report entry gets older and harder to remove. The second thing is self-blame. There is a deeply embedded cultural script in the United States that says if you got a bill, you owe it. If it went to collections, you must have failed to pay something. This script is so strong that many people pay medical collections, including erroneous ones, not because they've verified they owe the money, but because paying feels like restoring order. It feels like taking responsibility. The psychological cost of walking around with an open collection is higher than the financial cost of just paying. And the industry knows this. The CFPB surveyed consumers who had paid a disputed medical debt without fully resolving the dispute. The most common reason they gave was not, "I decided I owed the money." It was, "I wanted it to be over." That is not a financial decision. That is an exhaustion decision. And the system is engineered to produce exhaustion on a schedule. The third thing is complexity as a weapon. The dispute process is not designed to be used. It is designed to exist, to satisfy legal minimum requirements and provide a paper defense against regulatory action, while being sufficiently burdensome that most people abandon it. The CFPB has documented this pattern explicitly. When disputes require coordination across the original hospital, the revenue cycle company, the debt collector, and 3 separate credit bureaus, each with different timelines, different evidence standards, and different points of contact, most people do not complete the process. Not because they're unsophisticated, because they have lives, and the system is counting on that. This is not an accident. Complexity is a feature. Here's what most people don't realize. The hospital billing system was not designed around patients. It was designed around reimbursement. The codes, the processes, the clearinghouses, the revenue cycle companies, all of it emerged from a system built to optimize insurer payments. Patients were an afterthought, reachable only after the insurer pathway was exhausted. When the insurer pathway fails, even due to the hospital's own error, you are not a protected party in that system. You are a backup collection target, and the people most affected by this are not the people best positioned to fight it. KFF data consistently shows that medical debt falls disproportionately on people with lower incomes, Black and Hispanic Americans, and people in states without Medicaid expansion. These are also the people with the least access to consumer law attorneys, the least flexibility to spend hours on hold with billing departments, and the credit scores most damaged by an erroneous collection. The system extracts more from the people with the least margin to absorb it. That is not an unintended consequence. That is how extraction works. The human cost of the system compounds in ways that don't show up in the headline number. Take the credit score damage. A single collection account, even a disputed one, can drop a credit score between 50 and 110 points depending on the starting score and the account history. That drop has real downstream costs. Higher interest rates on auto loans, mortgage applications flagged or denied, apartment rental applications rejected, In some states, even job applications affected. The Urban Institute estimated that Americans in communities with high medical debt face compound financial barriers, difficulty accessing credit, difficulty building assets, difficulty leaving high-cost rental housing, that persist for years after the original debt event. And remember, the debt itself may be entirely incorrect. You may have never owed it. The hospital may have simply failed to bill your insurer on time. There is documented reporting from ProPublica and KFF Health News of patients who discovered a medical collection only when they sat down with a mortgage broker and were told their application was denied, not flagged, denied. The collection had been on the report for 7 months. The debt was from a covered procedure. No one had called. No one had written. The first notification was a loan rejection. There are documented cases covered in reporting by ProPublica and KFF Health News of patients who spent months in a bureaucratic loop between the hospital, the revenue cycle company, and the collector, never receiving a coherent explanation of why the claim wasn't resubmitted. Patients who ultimately paid the disputed amount because the mortgage was time-sensitive and the dispute timeline was not. That is not a system malfunction, that is the system working as built. The No Surprises Act, enacted in 2022, addressed some elements of unexpected medical billing, primarily out-of-network surprise bills from emergency situations. But it does not require hospitals to notify patients before sending accounts to collections. It does not require revenue cycle companies to rework denied claims before routing them to patient billing. It does not give patients a right to demand resubmission to insurance. The gap this video is about, billing errors that create collections debt from covered procedures, is not meaningfully addressed by existing federal law. The CFPB, under its 2022 to 2023 leadership, attempted to remove medical debt from consumer credit reports, arguing that medical debt is a poor predictor of creditworthiness and that its presence on credit reports creates significant harm without meaningful informational value. The credit bureaus have since agreed to remove some categories of medical debt from reports voluntarily, specifically paid medical debt and medical debt under $500. But unpaid medical debt above $500, including amounts disputed on grounds of billing error, remains reportable. The collections industry generated approximately $13 billion in revenue in 2022, according to IBIS World. A portion of that figure, no one publishes exactly how much, traces to medical debt that was never valid. Debt created by errors that no one corrected because correcting errors doesn't pay. That revenue has to come from somewhere. It came from people like Sarah in Ohio, who had insurance, who paid her copay, and who spent 4 months trying to remove something from her credit report that should never have been put there. Here's the verdict. R1RCM. Ensemble Health Partners. And the unnamed debt buyer who purchased your $3,200 bill for $160 and reported it to 3 credit bureaus before you knew it existed. Those are the names. Those are the companies. The machine has 2 engines. Revenue cycle management firms whose contracts reward patient collection over claim correction, and third-party collectors who profit from the gap between what they paid for your debt and what they can extract from you. Both profit from a single moment. The moment a billing error goes unresolved long enough to become legally your problem instead of theirs. The total is $220 billion, sitting in collections, right now, from people who had insurance. 2 things you can do right now. 1. If you receive any medical bill, not an EOB, an actual bill, request an itemized statement in writing before paying anything. You are legally entitled to this. Compare it against your insurer's explanation of benefits. If there's a discrepancy, call your insurer first, not the billing department. Ask whether the original claim was denied and why. Document every call with a date, time, and representative name. 2. If a medical collection appears on your credit report that you didn't know about, file disputes simultaneously with the CFPB at consumerfinance.gov and with each credit bureau in writing. Do not call. Written disputes create a paper trail the collector must legally respond to. If the collector cannot verify the accuracy of the debt within 30 days, they are required to remove it. These are not solutions to the system. The system will keep running. But they are the specific pressure points where you can interrupt the extraction before it completes. One more thing. If you go through this process and the hospital acknowledges the error, get that acknowledgement in writing. A verbal confirmation means nothing to a credit bureau. A written statement from the original creditor that the debt was submitted in error is the single most effective document in a credit dispute. Most billing departments won't offer it. You have to ask for it specifically. Ask for it specifically. $220 billion from people who had insurance, from people who paid their copays, from people who did everything right and got a collections notice 6 months later because someone on the other end of a billing software queue submitted the wrong 4-digit code, and no one felt financially motivated to fix it before the clock ran out. A lot of people say hospitals are just overwhelmed. Staffing shortages, coding complexity, the whole thing is an honest mess. And there is truth in that. But here's what I can't get past. The same system that can't find the time to resubmit a denied claim can absolutely find the time to sell that account to a collector. That asymmetry is not a staffing problem. That's a priority decision. Tell me if you see it differently. Has a medical bill ended up in collections before you even knew it existed? Drop it in the comments. I want to know how it played out. Whether you fought it, whether you paid it, and whether anyone at that hospital ever explained how it happened. Because I've been reading those threads, and I think you already know the answer to that last one.